Thank you, Sarah, for that lovely introduction. As you pointed out, I will be speaking about other therapeutic techniques, including the feeding environment. Firstly, I am going to touch on some key points that have been highlighted throughout this presentation. We know that there are specific methods by which we can search for clinical practice guidelines within our relevant area, such as the use of key terms, Boolean operators, and information gathering about where to search for these specific documents. We know that once a CPG is found, it must be evaluated in order to ensure that it meets our needs, both as a source of high quality, evidence-based information and a user-friendly document for the busy clinician. We are also aware of the tools we can use in order to carry out this evaluation, one of which is the Agree To tool. And through this evaluation, we have discovered that the Speech Pathology Australia Clinical Practice Guidelines for Dysphagia, whilst being a useful resource overall, has some issues in regard to the implementation of its key recommendations. For example, the recommendation that concerns compensatory strategies for dysphagia management does not cater specifically for the paediatric population. Furthermore, it does not capture the broad nature of dysphagia in infants when the disorder relates to the feeding process rather than dysphagia in its simplest form, that is, the ability to move food from the mouth to the stomach. We believe that as a team, we have addressed these concerns through the development of this resource for clinicians. So, without further ado, I will address the final area for which this resource provides clinicians with information and advice. The question may be asked, where do all of these other factors, such as the lighting of a room, fit in with therapy for dysphagia and feeding management? It is an excellent question and one that requires careful thought and consideration. These factors can be conceptualized as the methods by which the environment, rate of bolus presentation, or anatomy is adjusted to enhance the feeder's ability to engage in successful feeding. These strategies are often incorporated as part of a feeding treatment program and are considered compensatory in that they do not alter the underlying physiology of the inefficient swallow. However, may allow for the increased intake of solids or liquids. We believe that this resource is an extremely useful tool through which clinicians can search for these strategies according to the type of impairment they observe in their client. For example, if I were to observe an ineffective or insufficient suck in a highly distractible infant with a cleft palate, I would be able to search for an adequate posture or position to decrease their aspiration risk, as well as discover that this infant would be best suited to a quiet, dimly lit feeding environment. Speaking on behalf of this team, I hope that this presentation has both enlightened and inspired you about the work that speech pathologists do as part of dysphagia management in the paediatric population. I thank you kindly for listening.